like to invite all the speakers of this session onto the stage for question and answer session. Dr. Sumana, Dr. Shayas, and Dr. Gautam, please. Any questions from the audience?
Somebody's
Any questions?
I have a question to our own Dada. So, if I'm not an IVF consultant, I'm doing practicing basic infertility. So, in case one cycle is of OHSS, then should he cancel the next cycle or should he continue with the same treatment? What should he do? No, not the same treatment. I mean, what should be the next cycle?
You mean it is with IVF or with ovulation induction?
Just ovulation inductions.
In my opinion, you should cancel the cycle. You should not give HCG, because in an ovulation induction, you don't have much to lose. Or you can refer that patient to an IVF unit. If you have your own IVF unit, then convert it. But many a time, what I have found, my personal experience is, the outcome of IVF in those cases where you started as ovulation induction and converted to IVF is not as good as IVF. Now, this is very important that this patient develop OHSS on ovulation induction. So when you or someone else is doing IVF, they'll be taking lots of precautions, which I've already discussed.
And the next cycle, we should give a gap.
Dada, there was a question how long you can wait. Like, if she's had OHSS, so a gap of how much time? That's the question.
Yes,
Okay,
yes.
How long we can wait? Yeah, I think in my opinion, at least 1 month. At least 1 month gap is required because those follicles to go down. Now, what I personally do is I often put them on oral contraceptive pill for 3 months and then bring them back after. And that helps in getting those big follicles back to the normal size.
So take home message, at least wait for 1 month.
At least.
Got it? Thank you.
I want to ask a question. When we talk about ovulation induction, many times there is no distinction made between just oral ovulogens versus oral ovulation inducing agents with a little bit of gonadotrophins. I think we need to be very clear. These are two very distinct clinical scenarios, and many times when clinicians speak about OHSs, like 3 to 4 follicles also, they would call us OHSs. So I think I would really like the experts to give some clear-cut take-home messages about these two different clinical scenarios.
So actually that was a slide that I deleted for want of time. So mainly there are 3 concepts that we have to understand. So one is ovulation induction. Ovulation induction is stimulation of a single follicle in a woman who is anovulatory. So that is the target. So that's probably what we do in PCOS. Second is controlled ovarian hyperstimulation, which is perhaps what we do in unexplained infertility. So here the woman is already ovulatory and our aim is to get at least maybe 2 follicles to increase the chance of conception. The last is superovulation, what we do in IVF, where we create multiple follicles. So our aim in ovulation induction should be 1 follicle, where if the woman is anovulatory. And to answer your previous question, if the woman has developed multiple follicles, if it is more than 2, then you should cancel the cycle and give her a lower dose in the subsequent cycle.
I had a question for Shreyas. I mean, just a practical question. In a PCOS woman who's resistant, who is not conceived or is absolutely resistant to clomiphene citrate or letrozole or whatever, then we go on to gonadotrophins only and IUI, the topic that you covered. So do you think gonadotrophin only IUI is cost effective, time effective, and is it practical compared to just shifting over to IVF? Because you see sometimes you have to stimulate for 20 days, 25 days, then cancel. You have to counsel them about all kinds of things.
I think you have to give a chance to conservative treatments to start with. If she has just received clomiphene and she has not been successful in ovulation, I don't think I will ask her to do IVF. I will definitely try and see if, because a lot of these women will be amenable to ovulation induction with gonadotrophin. And in fact, in your first very cycle you will get an idea where she's growing. Now, if you grow up to 150 units and if she's not doing well, of course there is a chance. In fact, for such women, I would counsel them that we are going to try now, but if you do not respond to higher and higher dosages, maybe at some point you will need IVF. So, but not before trying.
And also a question to Gautam. When you're giving metformin only for prevention of OHSS in your IVF patient, do you have a dose, fixed dose, or will you give the dose according to patient BMI? If so, what is your usual way of prescribing?
According to patient BMI, we usually start, because of the side effect, we start with a smaller dose, maybe metformin 500 milligram once daily, then go up to twice or 3 times daily. If the body weight is very high and insulin resistance factor is, we have been using 800 milligram, 3 times daily. But this should be started at least 2 months, if not 3 months before doing. That's what we did in papers. It should be at least 8 weeks before starting.
The standard teaching used to be that at least 1500 or 1700 grams.
That's
if
what the latest
you don't give,
recommendations.
then it's not supposed to be effective. But what is your take?
1500 we give. 1500. Majority of cases we give 1500. We start with a lower dose.
If the patient is already on metformin for insulin resistance or for weight management, then we continue and we increase the dose. But if we are doing an IVF cycle and we would like to start metformin for prevention of OHSS, the minimum dose would be 1.5 grams to 2 grams per day. And it can be just started with the start of gonadotrophins.
And I think that can be based on BMI,
And
because
would
some
you
new
agree that
papers
it
are
has to be-
suggesting that it doesn't have to be a very high dose for it to be effective. It can be effective at low doses also. That's
But
why
it
I
has
want
to be
know.
given for a certain period. You cannot just start and do IVF.
Then that's what Dr. Gautam, if I interfere, it should be given at least 3 months before you take up the patient for IVF,
At least
so
2
that you get
months.
better results
Yeah.
and you prevent OHSS. And the maximum dose you can give is, I think, up to 1.5 to 2 per day. Am I right?
Yeah.
Thank you.
Any more questions? One.
Is there any point in asking your patient to sign a OHSS disclaimer?
No, we always do. We always do, because in the consent form, it is always written there is a risk of OHSS.
For every patient?
Yeah. All consent forms have the risk of OHSS. We always say. Now the issue is, often patients ask how much is going to cost. That you cannot answer.
No, but you also said that this is an iatrogenic condition.
Yes.
So where's the legal standing there?
Well, legal standing is cancelling it. Yes.
Yeah.
Yeah. You can always cancel.
So it's not totally in our hands.
Yeah.
Whether the
I mean,
patient
I've
gets an
forgotten
OHSS or not.
when I've last continued the cycle with OHSS. We all give GnRH, agonist, trigger and freeze. But in spite of that, you cannot completely eliminate
True.
OHSS. So we have several agents like capgolin, like HES, like calcium gluconate, antagonist. These you can use to reduce. But this is one thing, it's totally unpredictable.
Yeah.
And that makes
That's
it
what
very
I'm saying.
frustrating, very frustrating. You cannot predict.
So it's better to take a sign. Okay.
I mean, just to save our skin, there have been some reports of OHSS happening in spontaneous singleton pregnancies, where no ovulation induction or gonadotrophins were given. So it may not be an entirely iatrogenic complication. We may have some other evidence as well. I think we can go ahead with the presentation.
Yeah. Remaining questions we can ask in the lunch break. We thank the PCO Society for giving us the chance today. Okay.
Good afternoon, everyone. So let's start with the case presentation. We had a patient who was married since 5 years and she was 35 years old, came to us with a primary infertility of 3 years. She had history of chronic anovulation, typical irregular cycles, and a significant history of weight gain of almost 10 kgs in the last 2 years. She had done a few fertility treatment cycles outside, especially IUIs, 4 cycles, 2 with letrozole and 2 with gonadotrophins, but she did not conceive in either of the cycles. Both the cycles showed good follicular growth and good endometrium growth with a decent post-wash count, but she could not conceive. When she came to us on examination, we found that she has hirsutism with an FG score of 10 and acne since 2 years, and this was specifically noticed after her weight gain started. She also had acanthosis nigricans and a raised BMI of almost 30, falling in the obese category. On labs, we found that she had insulin resistance with a raised HOMA-IR of 4.6. Her AMH was 2.8, while androgens were normal, so she had no biochemical hyperandrogenism. Her baseline FSH revealed a value of 8.2, LH was 8, and a baseline estrogen of 30 on day 2 of cycle. On sonography, we found that the ovaries had raised volume of almost 13 and 15 cc's and an AFC of 12 and 12 on each side. We also examined the husband. He was 35 years old with no significant medical or surgical history, but we found that he did have asthenospermia with a total progressive motility of only 15%, while his count was 20 million. So she was diagnosed with PCOS in view of chronic anovulation, clinical hyperandrogenism, and polycystic morphology on sonography. In view of her failed IUI cycles, asthenospermia, male factor, and advanced reproductive age and PCOS, she was advised IVF. So the plan of action was to encourage her to lose at least 5% of her body weight prior to the treatment cycle, and she was also given metformin for correcting the insulin resistance. The couple was counseled for a freeze-all cycle in view of PCOS, and they were also counseled about the possibility of ovarian hyperstimulation syndrome. The cycle was done using an antagonist protocol, and recombinant FSH of dose of 225 IU was started from day 3. The dose was considered in view of her age, FSH value, and raised BMI. On cycle day 7, we found that when the follicle reached 14, an antagonist was started, and the serum estradiol on that day was already 3,700. The same dose was continued till the final maturation of the oocytes, and a small dose of HMG, just 75 units, was added in the last 2 days, keeping the total dose at 225. Totally 4 doses of antagonist were administered, and the final E2 value was 6,800. And on sonography, we found that totally there were 12 follicles between 18 to 20 mm, 8 around 16 to 17, and 10 follicles of mid-size around 13 to 15. She was triggered with 0.3 mg of GnRH agonist, and a pickup was done 36 hours later. The endometrium looked good with 9 mm AAA and good flow. We retrieved 28 oocytes, 22 M2s, and ICSI was carried out for 22 M2s. 19 day 3 embryos were frozen. She was started on Capgolin for 8 days, oral contraceptive pills for 1 cycle, and daily antagonist injections for 5 doses. A record of her abdominal girth, weight, and urine output was maintained. 24 hours post pickup, she complained of nausea and some abdominal discomfort, hence she was called to the clinic for examination. We found that her vitals were stable. She was febrile, but per abdomen there was mild tenderness and a slight increase in the abdominal girth by 1 centimeter. Her labs were normal with a borderline hematocrit value of 36%, and sonography showed enlarged ovaries with no evidence of ascites. These symptoms were suggestive of mild OHSS, and the patient was counseled for the same and managed on an OPD basis. The pain was managed with paracetamol, and she was encouraged to drink to thirst rather than to excess, at least 1 to 2 liters of fluids per day. The fluid intake and output monitoring was done. She was advised to avoid strenuous exercise and sexual intercourse, and was monitored over the next 5 days till symptoms resolved. Thus, what we could see from this case was that mild OHSS can be managed conservatively in high responder patients, and even with the use of GnRH agonist, it still can occur, while HCG use can lead to severe or critical OHSS in PCOS patients. Thank you. .8.
So rather unusual.
Yes.
AM is 2.8.
2.8.
I would want to ask you if
12 and 12.
24.
AFC was 12.
So,
24.
24.
So you counseled the patient for a freeze-all and counseled for a possibility of OHSS.
Yes.
So you already in your mind had classified this person to be at risk of OHSS.
Yes, she could land up with
Yes. Then why was the starting dose 225?
So we considered that she was 35 years old, had a BMI of almost 30, and her FSH was 8. So that's why we thought, since because of these factors, we could start with a little higher
you
dose.
already have classified her as a OHSS risk. So what was the reason for 225? What was the evidence to starting dose? The problem is the key to control and prevent OHSS is the starting dose of your FSH.
Okay.
You can do whatever you want to do later on, but you cannot rectify where we start. So this is to be very, very critically remembered very, very carefully what you start with.
But
And I think
Shreya's 225 as a starting dose in a 35-year-old 30 BMI is not reasonable.
but this is the first IVF cycle, so you need to start
24
24 AFC.
24 AFC is one of the high risk factor.
See,
And the other issue is the choice of gonadotrophin, because now we have several papers saying that HMG reduces the dose of. So in high responders, my personal opinion is it definitely reduces the number of follicle and reduces the chance of OHSS, and it also reduces the chance of miscarriage.
Okay.
The quality of embryos are better. This is just my personal view, but it has been supported that HMG has this benefit of reducing the risk of OHSS.
Okay.
And also this issue, what Shaz rightly said, I would have started, if I was using FSH, I would have started on
150.
maybe 150 or 200, something.
Okay. But sometimes what we have seen is that when we increase the dose later on, many small follicles start growing. Like suppose we started with 150 and the patient doesn't grow quite well, and we want to increase the dose.
but then you need to define when you say not quite well. Okay, this is
Like
you
very
need
slow.
to know because once how are you going to monitor these patients? What I would do is if I start at 150, I would do a estradiol after 3 or 4 days of stimulation and see where the estradiol is going.
Okay.
Another 2 days, if I'm happy with the level, say about anything beyond 100, and in fact, a patient like that would have levels of more than 200 or 300 just after 2 or 3 days of stimulation. And then you will know that your stimulation is working fine. And the way you would take it forward is then scan her after 2 days, see where the follicles are, and then monitor her very carefully and see if she's following the growth pattern. And if you intervene, of course, in some PCOS, you will have a situation where the growth tries to plateau off. And you need to pick these people up and only increase the dose for those rather than, and in fact, even if you miss by 1 more day, I don't think it is very detrimental for the growing follicles because you are already giving some.
The other issue we need to discuss here, I think she developed 19 embryos.
Yes.
Isn't it?
Yes.
Do we really need so many embryos?
Yeah.
And it has been said that if you have more than 10 embryos, that is another indicator that she is going to develop OHSS. Now you might say that, of course, you didn't know there will be
That
so
she
many
would
embryos. But the right thing was freeze on.
She
That
was
is the most
counseled for that
appropriate.
in the first place. Yeah.
And how many cycles after this one you're going to transfer her?
At least for 2 months we would wait, let the ovaries come back to their original size, and then at least for 2 months.
Would you give her any therapy in between?
So we usually are giving 1 cycle of oral contraceptive pill.
Right.
And then call her for a baseline scan to check if the ovaries have come back to the original volume.
Very good. Excellent.
I think elective single blastocyst transfer would be the answer for freeze-all rather than having 3 or 5. There are such weird practices going on in this country in the name of IVF. People are transferring 9 embryos. This is something which we all sitting here may, find very. But this is
Up
true.
to 5 I have heard, but 9 is.
Nine is
so-
too much.
This comes from an embryologist who tells me that that's what people are doing. So really, yes. So that's what is
Another
happening.
comment that I would make
What
is
they tell them is that the bad quality embryos, let's not freeze them. They anyway are not going to give you any pregnancy later on. So we're putting 3 good quality embryos. With that, there will be 6 more bad quality embryos. They will not do anything. So all these practices have to be abandoned. We have to move towards elective blastocyst transfer.
but not for this patient, I guess.
No.
Okay, thank you. Time for lunch. Thank you, all the speakers, for giving your time and your knowledge. We'll gather for photo, of course, and we thank the PCO Society, especially Dr. Durusha ma'am, for giving us this opportunity. Thank you so much.